Good morning. 6:14. Well, so far I haven't heard anything which is going to change the direction that I travel to get to the office that I'm going to today. But I think on the other hand, maybe yesterday I hadn't any inkling of where I was going. Glaucoma is an ocular disorder in which the intraocular pressure is too high for the health of the eye. I said this at least 2 times before this because we're in glaucoma 3, but too often we can become mesmerized by numbers and think that a number is the driver when it's an IOP that's too high for the health of that eye. And so the example an example presented here is the case of a low tension glaucoma wherein damage is occurring in some form. Damage is occurring which produces a change in visual acuity, color vision, produces visual field loss, visual field defects when when the pressure is really not that high. Another example of the number issue where we become mesmerized by numbers is when we see a patient that has visit after visit pressures into the 20s and possibly even to 30, and they have no damage. They have no damage, visible or otherwise, to the eyes. And for those patients, we keep a closer watch because they receive a diagnosis of glaucoma suspect, and we see them a little more frequently in order to not let this insidious condition, this condition which does not produce any visible expression of the problem, get out of hand. And so those patients receive certain types of statements in their chart. Glaucoma suspect, pressures again today in the 30s, but no signs or symptoms of the pressure being too high. So they are a glaucoma suspect and they're seen a little more frequently. And we may eventually come to a determination that those kinds of pressures, those in the 20s, may just be baseline for this patient. We've talked about the production and circulation of the aqueous. We talked about some anatomical parts of the eye, which are critical in the production and outflow of the aqueous fluid. We have talked specifically about the fact that there are two major mechanisms for the pressure being too high inside the eye, and that is that too much aqueous is being produced, and secondly, the outflow mechanism is not great enough, through the trabecular meshwork and Schlimm's canal and the uveoscleral interface and the corneo-uveal interface and the venous drainage from the eye to remove the aqueous that is circulated from the posterior chamber to the anterior chamber, and then should normally go out through the trabecular meshwork and Schlimm's canal. Lastly, yesterday we talked about the trabecular meshwork, and it is a sponge-like net of collagen fibers which crisscross over each other, and the trabecular meshwork is at the junction between the iris and the sclera, and the aqueous percolates through the trabecular meshwork before it gets to Schlimm's canal. Gonioscopy. The gonioscopy, the eye's particular anatomical configuration got a tickle in the throat this morning. Due to the eye's anatomic shape, light that comes into the eye is into the anterior chamber angle, strikes the cornea in such a way that it can cause some total internal reflection of those light rays. And so seeing into the angle from the outside, which obviously we can't see the angle from the inside unless we put something inside the eye. But because of the direction of our light source when we're trying to evaluate the angle, this iridoscleral junction, some of the light rays from whatever source of illumination we're using, and most of the time it's a indirect ophthalmoscope with a lens of some sort to magnify things so that we can actually see what we're looking at. Many of these rays go through the cornea at such an angle that there is total internal reflection of these light rays, and they do not illuminate the area we need to see, nor do they allow us to be able to see the angle in a direct fashion. So the use of a contact lens or a contact lens in a looser form than we've ever talked about a contact lens. So what we're talking about is a lens type which actually comes in contact with the eye, is used to allow us to examine the structures of, air quotes, the angle, right? This iridoscleral angle where the trabecular meshwork is in Schlemm's canal. And there are two main methods of gonioscopic examination, direct and indirect. So a Kepi lens, K-O-E-P-P-E, a Kepi lens allows the examiner to look directly into the angle. A light is used for illumination, and uh, a microscope or a handheld lens, a microscope in the form of a slit lamp, right? And this Kepi lens placed on the surface of the eye, and therefore it's a contact lens, allows for evaluation of the angle. So the Kepi lens is used to allow us to venture into the angle, so to speak, by what this Kepi lens does. It changes the direction of light and allows us to see into the angle. And then some sort of magnification is used, either with a handheld lens. Starting to get complicated here because we only have two hands, and or a slit lamp, which is used for magnification. So the patient is usually lying down for this examination, and you can see top of page 4 this domed lens, which is held by the hands of the examiner and placed on the surface of the eye. You know, you put a little proparacaine on there, and this lens goes on the eye, and you can see by the rounded nature of this lens that light rays that emerge from the angle are bent appropriately by the curvature of the Kepi lens, allowing for the observation of the angle by the examiner. And that's called direct because it's not indirect. Indirect, right below this, says Goldmann or Zeiss lenses. Goldmann, like the Goldmann bowl, right? Zeiss has produced all types of optical lenses and equipment. The Goldmann and Zeiss lenses have mirrors in them by which the angle can be examined by reflected light, not refracted light, but reflected light. And the patient is seated at a slit lamp for the examination, and the slit lamp provides necessary light, source of light, and magnification. So light is directed into the eye, reflects off of all substances which are in its path, and is reflected back, and through the use of a direct observation, direct examination lens, like a Kepi lens, the individual can look into the angle. In an indirect fashion, the Goldmann or Zeiss lenses use a mirrored, angled mirror embedded in the lens to produce a reflected light, which can be observed and evaluated by the examiner. And in this case, we see at the bottom of page 4, we see a Goldmann lens that has a single mirror. And then at the top of page 5 and all of page 5 includes a picture drawn of a Zeiss lens that has mirrored sides to allow for seeing one direction of the angle and another direction of the angle simultaneously, although you're not looking at both at the same time. But it's possible to see into both sides of the angle at the same time. With the Kepi lens, you'd have to rotate it as you're examining the angle with this domed lens. With the Goldmann, you would have to move it because of the mirrored edge being just on one side of the lens. Let's push on. Examination. The examination of a patient with possible raised pressure causing damage inside the eye. History should, during the history taking, we certainly would want to determine what the chief complaint is, the medical history of the patient, the ocular history of the patient, any medications the patient may be on, and then certainly a detailed family history as much as the patient or parent of patients. In our hands, we're going to be talking to parents of patients because we don't see adult glaucoma patients for their glaucoma treatment. We see many patients who have glaucoma and then have concurrent problems like strabismus. In many cases, secondary to very poor vision because the ocular health of one eye is very poor. The chief complaint, past medical history. Well, the chief complaint is going to be generated by the parents because the patient in all likelihood is not going to be able to produce any kind of meaningful information as to how they're doing. The medical history, present present health history, ocular history, list of medications, all those sorts of things are going to come from the parents, of course. Visual acuity testing is very important. And this will generally, many of these patients will fall into this non-verbal or pre-verbal category and will need to have their vision assessed by one of two methods, either the induced tropia test or the binocular fixation pattern if they have strabismus. They will need a detailed refraction, and some of these patients, especially the ones that have an honest to goodness case of glaucoma, are going to be very photophobic, very light sensitive. And this type of examination, as well as an examination of the posterior pole, looking for optic disc cupping, will be very tough to do. But a refraction is critical for those patients who have a significant refractive error and need correction in order to be able to aid in the normal development of their visual acuity. We need to see whether there are any pupillary light reaction problems, whether there are any pupil problems at all. Anisocoria, relative afferent pupillary defect, which could certainly be an early sign of a unilateral optic nerve damage, and we can see how that would produce a relative afferent pupillary defect. In older patients that are capable of visual field testing, we would certainly want to perform that on a regular basis, looking for changes in, looking for visual field loss, as well as for serially looking at changes in their visual fields. Tonometry or the eye care or the tono pen or the applanation tonometry are all very important. I don't know. I mean, it's an accuracy issue. I was getting ready to say I don't know, the exact reasoning behind saying, well, I want a tonal pen on this patient. I want applanation tonometry on this. I understand that some are suspect. Some of the measurements with the eye care, for example, are a bit suspect as far as pressure is concerned, and that the glaucoma doctor is the one that's going to want to use applanation tonometry. On the other hand, you're not going to fly a 6-month-old into a slit lamp just to get applanation tonometry. There has to be a balance between, well, there must be a balance between getting some sort of ballpark number for the pressure inside the eye versus how much wrestling you have to do with the child in order to be able to get a pressure, and the consequences of the child struggling and fighting, and are we getting an accurate pressure to begin with. But in this line here under tonometry or applanation tonometry, there are several forms of tonometry here that are just very quickly mentioned. Applanation tonometry using an applanator tip that's placed in the device on the slit lamp to check pressures. There's a Schiot's, the Schiot's tonometer, which will be described in here further on. The McKay-Marg. These three are methods for testing intraocular pressure. Gonioscopy, the explained somewhat on the previous 2 pages, but the anterior chamber needs to be examined when the IOP is over 80, over 20 millimeters of mercury. The anterior chamber is shallow, or the patient's history is suggestive of what could be an acute attack of glaucoma. Pain, photophobia, epiphora, and the anterior chamber needs to be evaluated through the process of gonioscopy, which allows a view into the angle. Ophthalmoscopy, the direct ophthalmoscope, the indirect ophthalmoscope with a lens at the slit lamp or not, to look for changes in the optic disc. And certainly when a patient's been evaluated by a knowledgeable and experienced eye doctor, then a comparison can be made by the same person or even a different person with some facility in this type of examination in order to be able to determine if there have been changes for the worse or for the better in the optic disc. There are a variety of special tests. Certainly, some patients are hooked up to devices which check the pressure in the eye at regular intervals, looking for a diurnal curve, which is this evaluation at varying times during the day, and looking at the pressures at different intervals during the day. Fluorescein angiography, you're looking at changes in the eye as a result of increased pressure in the eye. Optic nerve function tests, such as color vision, contrast sensitivity, other physiologic tests like pattern reversed ERGs, acuity, perimetry, which is a perimeter is like a Goldman bowl, or perimetry in the form of visual field testing, and acuity perimetry can be applied to looking at changes in visual acuity in various fields, various parts of your field of vision. Visually evoked cortical responses. And this is just looking at electrophysiologic evaluation of the integrity of the visual pathway. A couple of quick things. We're on the verge of 30 minutes here. Yikes. The pressure of the eye normally is in the teens, and IOP levels are dependent upon production and drainage. And blockage of aqueous outflow is the most common cause of glaucoma. When the root of the iris is pushed forward and rests against the trabecular meshwork, it closes the angle. On the other hand, and so we would call that closed angle glaucoma. On the other hand, when the angle is basically open, but because of other degenerative changes that occur to cause the trabecular meshwork spaces to collapse or be covered by debris inside the eye, the pressure can elevate even though the iris is really sitting in a rather normally positioned place relative to the trabecular meshwork. So we'll stop here. We'll start with tonometry at the bottom of page 6 tomorrow. But we've had some terms introduced to us today that we had not talked before. Tonometry, this process of assessing the pressure inside the eye. Gonioscopy, this process of being able to evaluate the angle of the eye. We've introduced some different types of pressure checking devices, the Shiots, the applanation tonometer. We talked about a couple of types of lenses which are used for gonioscopy, the Kepi lens and the Goldman and Zeiss. And the difference being that the Kepi lens is this domed, non-mirrored lens, and the Goldman and Zeiss have these mirrored sides to them, which allow for a reflected angle evaluation of the trabecular meshwork and the outflow mechanism. So we'll stop there. Thanks for putting up with me and all these early morning presentations, which you don't have to watch in the morning. So take care. As far as I know, I'll still be on Wall Street today. Peace.